evening, and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us. I am Kendall Rock, Senior Social Media Specialist at Treece Medical Concepts. Treece Medical is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that is not taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get right into the presentation by our surgeon speaker, Dr. Michael Jarman of Chandler, Arizona. First of all, you are all listening to the webinar on mute, but you can ask questions throughout by clicking on the questions tab in your control bar and typing them in. We will be answering questions sprinkled throughout the presentation and at its end. We will also be emailing you an archived link of this presentation to refer to within just a few days. Lastly, I know that you will enjoy our speaker, Dr. Jarman, but if you are attending outside of Arizona, you can find locally trained Lapiplasty doctors in your own area to consult with by visiting our patient website, www.lapiplasty.com. There is a prominent Find a Doctor button at the top of the homepage, searchable by your zip code, that will show you surgeons in your area. With all that out of the way, I'd like to introduce tonight's surgeon speaker, Dr. Michael Jarman. Dr. Michael Jarman is a board-certified pediatric podiatrist and founder of Pediatric Foot and Ankle in Arizona, where he is dedicated to helping children walk, run, and play without pain. Since opening his practice in 2014, Dr. Jarman has focused exclusively on pediatric foot and ankle care, combining advanced treatment techniques with a compassionate, family-centered approach to diagnose and manage a wide range of conditions. Widely recognized as a leading authority in pediatric podiatry, Dr. Jarman treats conditions such as flat feet, toe walking, Sever's disease, and sports injuries, offering both surgical and non-surgical solutions tailored to each person's needs. He is also a center of distinction for Lapiplasty 3D bunion correction surgery, providing families access to one of the most advanced bunion correction procedures available. Dr. Jarman received his doctorate in podiatric medicine from the New York College of Podiatric Medicine. He is board certified in foot surgery and reconstructive rear foot and ankle surgery by the American Board of Foot and Ankle Surgery, a certification representing the highest level of surgical expertise in his profession. He is also a fellow of the American College of Foot and Ankle Surgeons and an active member of the American Podiatric Medical Association, the American College of Foot and Ankle Surgeons, and the American College of Foot and Ankle Pediatrics. In June of 2020, Dr. Jarman was recognized as a master hypocure surgeon, reflecting his advanced skill and experience in treating pediatric foot deformities. His research contributions include 2 published papers in Podiatric Today, Essential Principles in Treating Diabetic Forefoot Ulcers, and Can Early Correction of the Hypronation Help Prevent Secondary Deformities. Beyond clinical practice, Dr. Jarman is so deeply involved in education and research, offering virtual consultations and serving as a trusted resource for patients, podiatrists, and pediatric healthcare providers worldwide. His expertise has earned him national and international recognition for his commitment to improving children's mobility and quality of life through expert evidence-based care. Outside of work, Dr. Jarman treasures time with his wife and 5 children, who he calls the highlight of my life. He strives to live each day to the fullest and brings that same sense of purpose and compassion to his work with every family that he serves. We appreciate Dr. Jarman volunteering his time with us this evening. I will return to moderate a question and answer segment at the end. And now for Dr. Michael Jarman.
Thanks, Kendall. I appreciate you allowing me to be part of this webinar this evening. In the pediatric world of podiatry, it is very fascinating because one of the most common things I feel like gets confused is that kids and adults are the same, and in some ways they are, but in most ways they're not. And in the bunion aspect, and that's what I think Lapiplasty is intriguing and fascinating, is that kids get bunions and kids have foot pain and lots of kids need help. And in my day-to-day, I do a lot of surgery, I do a lot of conservative care, and bunions are performed on kids and have a place. And a lot of what I want to speak on this evening is going to be just in general information about bunions and Lapiplasty and their indications, but I'd also like to kind of speak on my experiences that I get to see with children and how we treat them very specifically in the surgical world. The Lapiplasty's been out for a long time. Now, I came out in private practice in 2014, where I started private practice. And so all my training was pre-Lapiplasty. And what that meant is that when we were learning how to do bunions, you would say in residency and in school, you know, we'd say that there's 25 different ways to fix a bunion, meaning there's 25 different procedures. And just there's lots of, you know, you're using protocols and metrics to determine severity and other issues on how, or other factors to determine how you're going to fix it. And so you got to see a lot of variations in what doctors did to fix it, but you also got to see lots of variations in outcome. And that was the hard part about bunions, is that like with Lapiplasty, it just changed everything, because Lapiplasty now gives one, reproducibility with bunion correction, but reproducibility amongst not just surgeons, but reproducibility within your own patient group or your patient base. So it's something that I just fell in love with. But it's a patented procedure. Treece Medical is the manufacturer. It does require training. So when I came out and started doing bunion procedures, in my early years, I was doing, they're called long arm Austins. So any surgeons that are listening to this know what a Kalish is. Maybe that's an academic word now, because I don't know of anyone who does a Kalish bunionectomy, but that's how I did them, long arm Austins. And I thought I was the cat's meow back then. And I had a doc that joined my practice after I'd been in practice for a couple of years, and he said, "Hey, I've been playing around with this this new technique called Lapiplasty." And initially I was like, I don't know. I've heard about it. I don't know if I'm willing to do that. I'm really kind of set in my ways. And the third surgery that he showed me, his X-rays and his patients, because they were in our, you know, shared our office. I said, I got to try this. That's crazy, because I'm looking at this doctor that has done, you know, 3 Lapiplasties, and I know I've been in practice for a long time, and I've done just a ton of bunion corrections, and I'm like, that looks amazing. And he was getting reproducible outcomes and excellent correction, and that's kind of how I came on board with Lapiplasty. So with the bunion procedures, can we have, you know, adverse effects or events? And sure, you can have infections, you can have pain, you can have numbness, you can have issues with the implant or the osteotomy or the arthrodesis, the fusion not taking, where you get a non-union or malunion, or, you know, mispositioning because the bones didn't heal up. And these are very rare, but in my world, in the pediatric world, these actually kind of don't exist. And that's the amazing thing about kids, is they want to heal. You know, we're not dealing with, most adult podiatrists or podiatrists who are doing bunion correction on adults. I think the average age is around 50. And I think that age comes about because as adults, as we're working and we have life issues, and we're like, oh, I can't take the time off to get my bunion fixed, and so that's the kind of the mental thought. And so they kind of, their life is winding down per se. So I'm pretty close to that age myself, so it's not winding down. But you know, you finally get to a point where you break and you're like, all right, my foot really, really hurts and I want to take care of it. And so you have the procedure done. But as we get older, we have other things that are going on. You have health issues, you have metabolic issues, you know, you have diabetes, maybe thyroid issues, hypertension, obesity. And these play adverse, these are the adverse events that create risks in doing these procedures, because Maybe you have osteoporosis and the bone quality isn't great. Some might take a little bit longer to heal. In the pediatric world, in my world, I just don't have to deal with that, and that's what's great, because again, I can do these procedures, and with the Lapiplasty, of course, you can be walking right away, but in the kids, they can walk right away, but they heal up crazy fast. So we'll talk about this later, but in 4 weeks, they're healed up for sure. So what are bunions? We know what they look like. You know, you're looking down at your foot and they're causing pain. There's discomfort. The pain is on that eminence, on that bump. It's on the outside. And this is where a good workup from the physician to make sure, you know, when we're looking at, are we candidates for bunions, as we talked about earlier, where's the pain really coming from, so you don't get misdiagnosed. But pain's coming from that bump. And we find that you'll get numbness, tingling, burning sensation. The shoe gear that patients will wear will kind of enhance the pain. And we'll see this in the pediatric population. And kind of that misconception is that you just shave it off, shave that bump off. But the reality is that bunions are really complicated. There's a lot of factors that are at play with why they come into play, but also where this instability is coming from and where should they be fixed. And a lot of this in my world is going to be genetic, not necessarily biomechanical. In the older adult that maybe said, well, I had a normal foot and then I developed a bunion and now I want to get my bunion fixed because it hurts. They may have a progressive deformity where the bunion has formed, and that's maybe because of biomechanical factors of the shoes they wore. You know, I worked on concrete floors or the activities we did that created the bunion. But in my world of seeing children, where I see newborn babies to 18 years of age, I'll see 6-year-olds, 5-year-olds that are being worked up or evaluated for a bunion, bad bunions. And these are genetic. And so when we have kids that are coming in, it's genetic, it's not biomechanic. When we treat these, this is fascinating. Again, when I was learning or I was taught and trained in residency, which was in Miami, Florida, excellent residency, excellent surgical competency that was gained through that residency. Again, I had 25 surgeons that I covered, and we did lots and lots of surgeries, but we also had 25 different ways that bunions were done. And the bunion being fixated or being corrected at the base, lapidus it was done, but it was really a lot of head procedures that were done. And the correction that was done in more of a 2-dimensional way. It wasn't what we call 3-dimensional, and the systems were different and they weren't quite as reproducible. Conservative care for bunion treatment is often what is done until a child is age appropriate in my practice. You know, we do use toe spacers. I do use pads. I do use orthotics. I do recommend wider toe box shoes until they are surgical candidates and that they are eligible to have these procedures. So how does the Lapiplasty, how does this work? And why does it work so well? And the Lapiplasty has the ability to realign to more natural, normal anatomy. Because of this 3-dimensional transformation that takes place, we're able to kind of undo all of this. And the Lapiplasty is correcting the entire bone structure of this foot, and also allowing these patients to get back to activities very quickly. The nice, beautiful thing about having bunion surgery in younger patients, and that's a very generalized term, and when I say younger, I'm not talking, a 13-year-old per se, but just younger patients, is that bunions, as they progress and get worse, the malalignment creates to other arthritic events or bone spurring events or hypertrophic bone formation. And this does become a problem or an obstacle when you do go to correct these feet. And so when you're able to fix these bunions and correct them once skeletal maturity has been reached in a younger patient, you're not dealing with all this other issues with hypertrophic bone or arthritis, because it doesn't exist. And so correction in younger patients before these other deformative forces take place, you get better outcomes for sure. And just the healing potential is just exponential in a younger patient too. And so not that I advocate that all patients with bunions get them fixed, and I don't advocate that all children with bunions get them fixed, but I do advocate that if someone is suffering with a bunion and it is painful and they do meet the criteria to have it fixed, I do advocate they have it fixed, because again, with the Lapiplasty system, you get reproducible outcomes, and they're great. They're really, really, really good outcomes. So the most common question I get asked from a parent and an older teenage child is, what happens if I don't fix my foot? And some of these that obviously are genetic, they may say like, hey, Grandma Velma here, her foot is ferocious. I don't want my foot to look like, my grandma's foot. And it isn't that all bunions go to become the worst bunion ever, but when this is how this is Dr. Jarman speaking, is that if I have, a 14, a 15, a 16-year-old girl sitting, or boy sitting in my office and is already struggling with a painful, deformity of their foot, it's not going to just get better or go away. Orthotics don't fix bunions. Shoe gears doesn't fix bunions. Toe splints and toe spacers don't fix bunions. Those things can help. But again, these are things that can be fixed through a skilled surgeon who knows what they're doing, been's trained, and uses a system that has reproducible outcomes. These are home runs. And so, do bunions get worse over time? Yes, of course they do. We see that, we know that. We can see deviation of the big toe, we see arthritis, we see bone spurs, hammering of the digits. Yeah, bunions don't go away, unfortunately. So how do we recover after these procedures, and what does it take to recover, and what does it mean? I can tell you in my experience in the pediatric world is that the recovery is very quick. We typically see bone fusion in these kids around 4, maybe 6 weeks. I personally do put a cast on these children, and that's not common at all, but I put a cast on right after the surgery for 2 weeks. I do this only in the pediatric population in younger children because of a compliance issue. When a cast is on, they can't hurt, but it's really a surgical incision site. I want it to close up nice and beautiful. And we find is that if we don't touch that incision site in the pediatric world for that first 2 weeks, they just weld together so nice and beautifully. And these children have no pain, no discomfort. And then when we take that cast off at 2 weeks, the incision site's healed up, everything's pretty stable. And then I put them into a walking boot and they can start putting pressure on that boot. And then typically at that 6 to 8 weeks is in common in the adult population, but I typically find that a little earlier, maybe around week 4 to 6, is that these kids can transfer back into shoes. But as far as their weight bearing, there's no running, there's no jumping, there's no trampoline, because that is a problem in our younger population. And that bone just grows right back together, fuses, and is solid. And then in the adult population, 4 to 6 months, they're doing pretty good, where they're not having everything's healed up. There's minimal scar tissue, anything like that. But it's earlier in the younger child. Now, one thing that is not kind of discussed is, do you do both at the same time, or do you do one at the same time? And I firmly discourage ever doing bilateral cases. And there are doctors that can do them, but the quality of life is just not worth it. The risks of complications are, significant. In the pediatric world, it's not a big deal. Kids love being in a cast, for 2 weeks. It's a very minimal inconvenience for a younger patient who's in school, not really maybe even driving or doesn't have a job or career. It's not a big deal. So it's one at a time with Dr. Jarman. So the results, and obviously these are all adult feet, and in the pediatric world, again, incredibly reproducible. And typically the bunions, by the way, that Dr. Jarman gets, so that I'm getting, they're bad. you know, they're not little bunions. These are bad bunions because kids are kind of invincible. They really don't have a lot of pain. And it really takes a lot to get those painful, and it's typically the nerve on that medial eminence is causing a lot of pain. And so that's, again, the great thing about Lapiplasty, because you can take these really horrific bunions that have really bad or really large intermetatarsal angles, and you can close them right down. And then that first MPJ will just realign because there's no arthritis in it. It's not misshapen. It's not, you know, there's no incongruencies in it. And so the outcomes, again, the results are really good. Patients are very satisfied with them. So are bunions hereditary? Yeah, they are. In my world, it's highly genetic because that's how I see them. What do we do if you have a bunion? And the rules that I play by is severity and symptoms. Symptoms and severity drive intervention. 9 out of 10 patients who have bunion surgery, it's symptoms. It hurts really bad, and they need help. 1 out of 10, it's aesthetics, but there is some still functional issue, right? Shoe gear is limited, but the pain may not be out of control, but there's some aesthetic issues. But again, in my world, it's severity is really what's driving these. So how do you determine if a patient is a good candidate for the Lapiplasty? And again, this is going to come down to experience. It's going to come down to a good clinical workup. It's going to be looking at x-rays to see what the intermetatarsal angle is, what the uncovering of the sesamoids is, to make sure that the patient really is having bunion pain, because there are other, we call differentials. Patient may see the bunion, but it may be something else. For example, in the pediatric world, I get a lot of parents bringing their kids in because they say, my child has a flat foot, and they think that they need an orthotic, and then you take an x-ray and you're like, oh, actually you have a coalition, or you have a fracture, or you have, you know, some other anomaly in the foot, and it's, you know, yeah, you got a flat foot, but that's actually not what the source of the pain is. And so good workup, because that's the worst thing to do to a patient is you say, hey, you've got a bunion, you fix it, and then they're like, hey, I still have the same pain. My foot looks good, but why does it still hurt? So you want an accurate diagnosis. It's really important, and you're going to get that from a skilled surgeon, someone who does, you know, bunion surgery regularly. So my bunion is moderate. It's severe. So is there a bunion that is so severe that it cannot be treated? No, that is not true. And we welcome those. I think that what we do find is that obviously in the more mild and moderate, there less correction is needed. So maybe it's a little easier for the surgeon to get the correction. And as it gets more severe, you're still going to get correction, but maybe it's not perfect correction. From the surgeon standpoint, we critiqued ourselves quite seriously, in the sense of like, we want the best outcome. We want it to look good and perfect. We want it to be better. Our expectations are almost higher sometimes than the patient's. But from a patient standpoint, you know, again, if they have a severe bunion and you correct it 90% to them, that's, you know, that's a home run. So what if you've already had surgery before? Can you get the Lapiplasty? Yes, of course you can. You know, we'll find is that when I was alluding to earlier in my surgical training, is that when I would, in my training and residency, 25 doctors in 25 different ways. And unfortunately, some of these cases I'd scrubbed when I was in Miami. And I remember walking out of that surgery, having watched the surgeon correct the bunion and following up, and often wondering how much correction did we get here? Because some surgeries or some procedures are just really inferior. I mean, yeah, it looks better, but you know, it's not great. But in doing a revision, if there's hardware in there, great, we just take the hardware out. But that's the beauty of a Lapiplasty, is you can still realign this foot. You can still have bunion surgery. And again, how is it different? And it's different. It's so different in that the mindset that I had and the training I had prior to Lapiplasty, I was resistant to changing because I felt I had superior training. I felt I was the cat's meow with bunions. And it was through seeing it done differently and being open-minded and just understanding that it is different, that there's a three-dimensional shift that corrects these. And yeah, it changed everything for me. And I would never go back to the other way. Even in a mild or moderate, I would still do the Lapiplasty, because again, how powerful they can be in correcting these deformities. So is it covered by insurance? Yes, of course it is. All insurances cover bunion, because bunions are painful. Bunions are have medical necessity, but we always verify, always, in my office, we have surgical coordinators and insurance verificators that do all that, do the homework for patients. And so patients don't need to call their insurance, or, parents advocating for their child don't need to call the insurance to figure it out. The office does. I don't personally do it because it's not my responsibility, but we have office staff that makes all that happen for us. And so again, going back to Lapiplasty is, only a surgeon can tell you if the Lapiplasty is correct, but obviously you can use a lot of good judgment. And if patients out there are watching these webinars and reading up on their material, or have already had maybe a workup, they'll know if they're a candidate or not. And Lapiplasty also has a wonderful tool for find a doctor. And this is where you can look at doctors in your area that obviously perform this routinely. And what's quite amazing is that you can also see how many, these surgeries that they actually have performed. And so it's a wonderful tool to kind of know who does these, who's good at these. So if you're trying to make that surgical decision. So yes, if there's any questions, I'd love to kind of filter some of those.
Thank you very much, Dr. Jarman. I think you had a pop-up close if you want to close that one out. There you go. We've had several questions come in this evening. Thank you for the great audience participation. We're going to do our best to answer most, if not all, the submitted questions right now. If you haven't yet, as a reminder, you may ask a question by clicking on the questions tab in your control bar and typing it into us. One of the questions that did come in was, what are your thoughts on a patient having history of juvenile RA and flat foot, pregnancy affecting bunions with added weight, age of 33 as a potential patient?
So this is the complications that, or they're not complications, these are obviously complicated cases. So I guess let me use some experience here, in that Lapiplasty is typically an isolated procedure, in that the majority of patients who are, and I want to talk about rheumatoid arthritis, and I also want to talk about flat feet. One of the issues is that we don't want reoccurrence. And so in patients who have flat feet, you have to consider the flat foot and be ready to either articulate why that's going to be a problem or why it may not be a problem. And if we believe it's going to be a problem, how are we going to address that? And the same with rheumatoid arthritis. So rheumatoid arthritis, I'm less concerned about, because the reality, when you're doing these bunion procedures, you're fusing a joint and you're getting rid of a joint that is going to be inflamed or possibly angry. And so it only can better the patient. So rheumatoid arthritis doesn't really create too much of a concern, especially in the pediatric world. So the majority of doctors, these are isolated procedures. There's not a lot of adjunct procedures that we add to the Lapiplasty. Sometimes we'll do on the toe, do an Aiken osteotomy, and that's just to straighten the toe out. Sometimes some docs will do what we call while osteotomies to shorten the second ray if we have a short first ray, and we'll do some little things. Now, in my world, I do combine flat foot reconstruction and bunion procedures with the Lapiplasty when necessary. And I actually did this last procedure last Wednesday on a young girl who had a severe flat foot and a severe bunion. And I combined a couple different procedures. And I've done this over the years on many patients. And something with hypocure, I've talked about hypocure. I like hypocures. And if the patient's a hypocure, I often will put a hypocure in with a Lapiplasty bunion procedure. If they're not a candidate for hypocure, I often will do a calc slide, sometimes even an Evans. And I have even done cotton osteotomies combined with the Lapiplasty. And these are not necessarily mainstream by any means, but sometimes you have very unique cases that need extra work. And when appropriate, we do that. Some doctors may stage it, some may try to do it, but this is a doctor's preference, and a good workup would really determine what the best course of action for this patient would be.
If a patient is needing a procedure to be done on their right foot, what is your recommendation for when they can start to drive again?
Yeah, so we find I would have no problem with them driving at 3 weeks at all, because of the stability that the hardware creates at where the correction is for the procedure. So when we fuse this joint, there's 2 locking plates that are placed over the fusion site, and those locking plates provide instant stability. So prior to me using Lapiplasty, a decade ago, I would use crossing screws, or I'd use a staple. And we had a lot of problems with non-unions at these joints for a Lapidus procedure. And those non-unions, they're hard to deal with when you get those. And we would immobilize patients for 6 to 8 weeks. You could not walk, put any pressure on that forefoot, because we did not want them messing up the surgery. And that creates a lot of problems, creates stiffness, it creates just a lot of problems. With the Lapiplasty, because of the way the fixation is done, it allows early mobilization. So there are some doctors that feel very comfortable letting these patients mildly walk. You gotta be very careful how we say walking, because that's not a universal term, but maybe applying slight pressure initially right after surgery. But week 3, I feel incredibly confident that a patient can put weight. Now, they're not running, jumping, or doing trampolines, but if you're driving, you would be able to drive with that foot, but you would just use caution.
What are your thoughts for a 63-year-old female with only occasional pain, but she has bilateral bunions? What would be your first steps?
Yeah. So if we were convinced that the pain was coming from the bunion itself, right, and that's where their patient's going to have pain on that inside of the bump, medial eminence, and they'll get a numbness, tingling. Sometimes it's reproducible because you'll just tap on it, push on it. It really has to do with, what do the x-rays look like? What are the patient's expectations? What is the quality of life that that patient has? And to determine, are they really a surgical candidate? Because again, I love Lapiplasty, but is Lapiplasty for everybody? No. Is it for a lot of patients? Yes. And so if the decision was made that surgery was correct, and that for her in her period of life where she was, and she could handle the recovery, and she had a support network, and we didn't see any kind of other comorbidities that were going to complicate, yeah, I mean, just say, you do one at a time, let one heal up, stage the other one, do it next year. And that's a beautiful thing about bunions. I do like to stage them. I do kind of like parent or patients to be like, hi, you're going to do one, and let's do the other one when this one heals, typically by, I say 2.5 months to 3 months. It's kind of where I make a recommendation that you can be doing it. It could be done a little sooner, but there's no requirement that it has to be done at a certain time. So you stage one now, stage one later.
Great, thank you. Can you fix a hammer toe and bunion done at the same time? If you also have the start of osteopenia in the foot as well? This is a 62-year-old female asking this question.
Yeah, so there are surgeon preferences, and so like I'll give you an example today. Wednesdays are my surgical days, and I did a procedure today, and I did 3 procedures on a flat foot reconstruction, and I added some stuff that I don't typically add, and it was to help the patient. And it took a case that was going to be 2 hours to 3 hours, and that's pretty extreme. And some doctors, it can complicate things if they have to add other procedures or add time. I kind of look at it as what's the value that's going to be added. I also look at comorbidities, right? Because in an older patient, this kind of might be the one and done. And in a younger patient, you can stage things and lessen the surgical time and complication rate post-operatively. Because if you do a hammer toe, hammer toes can actually sometimes even be more complicated, honestly, than bunions, because they're small toes. You can have a lot of problems because the small toes and how you fixate them, or do you fixate them, and where's the pain coming from. But I typically would make a recommendation to, yes, fix the hammer toe at the same time, but this is very physician specific, whether or not they feel comfortable in doing that for that patient.
Thank you. In your experience, what exercises, if any, would you recommend a patient to do pre and post-op to make their recovery more streamlined?
Yeah, that's a great question. So a lot has changed with pre-Lapiplasty. PT was always involved because there was so much fatigue and atrophy of the muscle because the patient had been immobilized for so long, and they really needed gait training and range of motion, and they were always sent to physical therapy. In the pediatric world, it's very rare that kids need physical therapy post-operative for bunions, only because of how quick they are walking and their immobilization and the healing things. I typically find patients need, I just say walk, but I think some of the common issues are the surgical incision site discomfort or scarring or adhesion. Sometimes that can be what really kind of hinders patients. And so I typically say massaging the foot, walking. If patients are having some discomfort, of course, PT and some gait training, or again, range of motion exercises. And I kind of just leave it up to the physical therapist to kind of evaluate what they think might be best to help the patient. But in general, I don't find in my practice that patients need a lot of stretching or physical therapy or activities outside of that, other than them just walking and moving.
Great, thank you. In your experience, when can an adult return to work, assuming there are no complications post-surgery?
So this is a funny one because, you can tell that I rely a lot on what does the patient want, because there's a difference between what the doctor says you can do and what the patient wants to do sometimes. And that's kind of a funny thing, because a patient might be like, well, I work on concrete floors and I really would like not to have to stand. Can I just get the next, 4 to 6 weeks off? And you're like, sure, I don't care. Because, they're like, I'd rather be at a desk job. And, but do they really need to be off their foot that long? Likely not. But maybe so. I mean, if you're working, in a factory, yeah, it's probably not a great idea to be walking. If you're sitting if you're really kind of like an office job, you could probably go back to work, I mean, within a day or two. There's a lot of variation. So a lot comes down to, what do you do? What kind of demands are placed on you? How much do you move around? Are you capable of using a knee scooter during, the first couple of weeks of recovery, or crutches? But patients can be mobile right away, because the surgery is kind of in the midfoot, forefoot. And so patients can put pressure immediately on the heel. So like showering and bathing, that can be done, right away, like transitioning. You need to go to the bathroom, you get in the shower, you can't get the incision site wet, but you can put pressure on your heel and just be careful. So day 1 after surgery, you can put pressure to that limb. We just don't want pressure to the ball of the foot.
Great, thank you. Can you briefly describe what exactly Lapiplasty is and how it differs from the old way?
Yeah, so the old way that I used to do it was called a long arm Austin, and this is called a caliche osteotomy. And I think that this is now almost more of just literature review stuff, because I have not yet met anyone that does that procedure currently. So back in the day, well, actually, let me show you this. When I have, let me work it backwards. When I have a patient that comes into the office for consultation, and I like to show visuals. I like to pull up before and afters of my own patients and videos of my own patients, of their feet, them walking, and what it looks like. Because it's such a powerful tool. We can go online and we can look at what other doctors did, but I really like them to see what I do and how I do it. And the fascinating part is that I'll pull up a not an X-ray, but an actual picture, a live picture of someone's foot from the outside, because patients, yeah, you can look at an X-ray, go, yeah, the bone looks great, but what does the foot really look like? That's what patients really want to know. And there's really not a lot of pictures online that show this, by the way. But I'll say, when you look at this foot, right, what do you see? And they're like, oh, the toe looks so straight. And I was like, yeah, it does. Because I'll show them like one foot done, the other one's not. But then I also ask them, I says, where do you see the incision site? And you can just see the wheels turning, because the incision site's not where the bump is. It's actually in the midfoot. And they find this very confusing. So, out there in the world of those, people who don't know what bunion surgery is, never seen it done, never watched a video on it, or maybe have, but don't understand Lapiplasty, is that the correction is made at the midfoot level, because that's where the deformity is. And so then I love to show them the X-ray and help them understand why we fix it there. And you just see everything, kind of all the pieces come into play. So when I used to do bunion correction, I used to do, if that's a word, right, or a phrase, I would do them at the head of the bone where the bump was. And I'd open up the foot, I'd make all the cuts, and then I would slide all the bones together. And again, cat's meow, it looked great. One of the most common problems I have is the toe would always be stiff, because we would violate that joint capsule. The Lapiplasty changed everything, because now I don't violate any of that. The procedure is at the correct location of where the anomaly is. And again, we call this three-dimensional change. So we're actually able to derotate the metatarsal and the bone and put it back up underneath the sesamoids. And to someone maybe listening who doesn't know what bunion surgery is, that's a very significant thing. And with the older procedures, you cannot do that, and it does not do that. And so again, the Lapiplasty system and the technique, and that's what's really important about this, is that there's a protocol that is followed. And when we follow that with the Lapiplasty, you get really good correction and really good results. And that's what I saw with other providers, and that attracted me to want to learn this and do it, because I wanted those reproducible outcomes. And because having someone that already been doing it one way for many years and felt that I had good outcomes, again, it changed everything for me. And the doctors out there that have gone through those kind of growing pains would say the exact same thing. Now, new doctors coming out don't know any different, because they would never do it the other way. They wouldn't do it the old ways, because likely they were never taught those ways. And in the Lapiplasty, those new doctors that are doing Lapiplasty, right, it works great. So they have no desire to do something different.
Does the fusion compromise the foot's range of motion?
Great question. So the majority of patients who have these bunion deformities, that joint produces too much motion already. The natural motion that exists in that joint, I believe, is, and don't quote me here because I'm not a scholar, but I believe there's like 10 degrees of motion. It's not a lot. It's just a little, but in a normal foot. But in a patient who has a bunion, we typically see hypermobility in that joint. And so that actually is something we want to get rid of, because that hypermobility aids to this destructive process of, a bunion deformity. And so by fusing it, you limit that motion, you stop that motion, but you realign that motion or realign that joint so it's in a proper alignment with the other joints, the other bones around it.
In your experience, what time frame would you recommend a 61-year-old female patient could return to walking for exercise post-Lapiplasty?
Yeah. So at week, the variables that need to be verified is, has the bone healed? Has the the arthrodesis, where the fusion site was done, the correction of the bunion, has it actually fused together? If it's fused, go to town, start walking, run, jump, do whatever you want, because that bone is healed up. If it hasn't fused, right? And I think that that's where the concern sometimes can come with a complication in an older patient. Hence, I heavily advocate for younger patients to have bunion correction so that they're young and they're healthy, the outcomes are just phenomenal, and that they're not suffering through life with this problem. But in an older patient, there can be underlying metabolic issues, diabetes, hypertension, obesity, osteoporosis, and you can find that these can complicate any surgery, not just bunion surgery. What's nice about Lapiplasty, again, is that hardware that's utilized, that locking plate system, it locks that joint down, and even if there is a slow union to occur, it still keeps that joint stable to allow even slow bone to heal up if it even takes time. But at week 6, I'm typically taking x-rays in the office, and patients have already been walking. And if the x-rays look like their fusion has started to occur and we see bone ossifying across and the patient's not having pain, I take the restrictions away and I allow them to start not, again, not running and jumping, doing athletic activities, but increasing activities, but being cautious about pain, swelling, discomfort. But if a patient is seeing pain, swelling, discomfort, we'd actually ask them to stop, reduce that activity. I often will get, other imaging done, typically a CT, to verify whether or not the bone has healed. So if I feel like a patient's having a complication, I'm very quick to get, other medical imaging other than an x-ray to confirm that there is some bone healing happening. And if a patient does appear, because it happens that we get non-unions, delayed unions, if that happens, then we address that, whether it's, fix or addressing metabolic issues, getting a bone stimulator on board to assist in that bone healing, to sometimes even having that tough talk about revisional surgery when appropriate.
How soon can a patient expect to gain full range of motion back in the joint of their big toe? And additionally, how soon will they be able to rise up, say, if they were wearing a heel on the ball of their foot after surgery?
The range of motion thing, this is not complicated, but it depends on, did they have a procedure there or not? So whatever range of motion you have in that joint is the same range of motion you will have after a Lapiplasty, in my experience. Because if you don't touch that bit, and that was one of the biggest problems I had with the other procedures I was doing, is that I would violate that big toe joint. If you violate that toe joint, the capsule soft tissues that surround that joint will create adhesions, and those adhesions will reduce the range of motion in that joint. So if the Lapiplasty is done just by itself without any other adjunct procedures, the range of motion should be the same as it was before. If an adjunct procedure, sometimes we do remove some of the medial eminence or hypertrophic bone or bone spurs around that big toe joint. That can sometimes initially reduce the range of motion. But as the patient continues to walk, or we have them doing physical therapy or activities, manual activities to stretch that joint, it typically does return back to normal.
In your experience, have you seen plantar fasciitis as a result of having a moderate or severe bunion?
So I do not believe that there is any direct relationship between bunions and plantar fasciitis, but there are direct relationships between something called equinus and plantar fasciitis, and flat feet and plantar fasciitis. And so it can be, again, confusing because as a patient, and even sometimes doctors or maybe who are non-specialists may see the bunion and correlate, make some correlations here. But if there's a correlation, it would be indirect in that I'm not aware of it from a literature standpoint. And clinically, I've not had that connection. But do patients have bunions and plantar fasciitis? Of course, but are they connected in that the bunion caused the plantar fasciitis? No, I do believe there's lots of reasons why we get plantar fasciitis or supposedly plantar fasciitis, but flat feet are a very common phenomenon to see with bunions and plantar fasciitis. And so likely there's some sort of connection between the flat foot and plantar fasciitis, and the bunion is just kind of that third wheel out there that's getting some flack for it. But yeah, indirectly, possibly.
How soon can a patient shower or go swimming after the Lapiplasty procedure?
Yeah, I think this is going to be universal in general, but we say 2 weeks. But it has to do with how the skin closure was performed and other environmental factors at play, health of a patient, metabolic. When I say metabolic, that means like underlying other diseases patients have. But the skin typically wants to heal up at 10 to 14 days, which gets us at that 2-week mark. Some surgeons close this incision site. This is a tricky incision site sometimes because it's on the top of our foot. And when I was talking about why casts, like in the pediatric population, you should put a cast on these kids or young adults, because one of the problems, kids are, we say, invincible. If they go into a boot or if they have some pain there, they kind of can ignore it, and the strap of the boot goes over the incision site, and this has happened to many times, is the strap will put pressure on the incision site and cause a dehiscence, and then that will delay how long the incision site heals up. If we can minimize any type of water, bacteria to that incision site in that first 2 weeks or pressure, we find that we get the, that appropriate healing time of 10 to 14 days. And so incision sites should take about 10 to 14 days. They'll take longer depending upon, do you get it wet? Do you get it dirty? When I say dirty, not rubbing dirt, but dirty water. If you shower and water runs down your body, it's dirty and it goes right to your foot, and it'll go right into your incision site and it'll cause an infection. Is there pressure being applied from the bandages, from the boot, directly to that? That will complicate how long it takes. And so that's kind of how we look at it. But in general, 10 to 14 days.
Can you weigh in on patients who are currently taking weight loss drugs? Do they need to stop taking the drug prior to having the procedure done, or can they still take it at the same time?
Yeah, that's a referral to Ozempic and other weight loss drugs. And the answer is yes, you do. So you have to stop a minimum of 1 week prior to surgical intervention before. And every hospital and doctor has a slightly different protocol on how that is, but it's because it slows down gastric emptying, if I can say that word, emptying. You know what I'm saying? And it's an anesthesia issue, risk issue. And so, and this will happen just in any surgery. If you're on these drugs and you have not stopped, they will cancel your surgery and postpone it, unfortunately. But typically, on average, we'll say a week, maybe 10 days.
Great, thank you. We have time for a couple more questions. Can you elaborate on if this procedure has an age limit? In your experience, what is what is normal? Would you recommend patients who are older having a procedure done, younger? Like, can you kind of elaborate on that? We've had a couple questions come through.
Yeah. So this is a very hot topic. And so on my end, I only see kids. I see newborns to 18-year-olds. The youngest patient I've actually done this on was a 13-year-old, and that's the average in a female. And that's about the average age, because we find that around that age in females, the growth plates close down. In boys, it's typically 14 to 16. You should not be performing these procedures in children younger, and it's not the age, it's the radiographic age, not the intake sheet age. So when we are looking on x-rays and we're looking at the intermetatarsal angles and the variables that say, yeah, this looks like a bunion, it should be fixed, and do the clinical workup, there is a growth plate at the base of the first metatarsal, and that physis, if it has not closed down and you violate it as it's trying to grow, has the potential to change the correction you've made. And that risk is, or make that bone not grow. You may alter it so it stops growing and it wanted to keep growing. And so you don't do it. One of the problems you'll find though in the community, those who don't see kids, there can be kind of this concern about doing procedures on kids. So you'll find most physicians who only see adults aren't making recommendations to do bunion procedures on 13 and 14-year-olds. Whereas in my office, it's very routine because that's the patient population I get to see all day long, and then they meet the criteria for it. But there's never a good time to have surgery. There's never a right time to have surgery. But whether a child has surgery, at 13 or 30 will not matter with the outcome. And that's the takeaway I like to make to parents, is that it's not a priority to get this fixed. It's just to understand, yeah, they're a candidate. This is what can be done, and this is the method in which it should be done. And when you're ready to do that, make it happen. But it doesn't have to happen when your child's 13. But what we do find, unfortunately, is children are very persuasive, and children start to advocate for themselves. And there's a lot of pressure, not just from aesthetic view, right? Because I'm looking from surgery that they have to be symptomatic or they have to be really bad. And in my world, it's symptoms. Majority is just symptoms. They're just symptomatic. And obviously there's been exhaustion in conservative care. I don't do surgery on someone without saying, or having seen they're trying to shoe gear, they're trying to manage it with the splaying of the foot. But yeah, younger children can have surgery, again, meeting the criteria. And we're also looking at their aptitudes, their maturity. Are they mature enough to handle this and do this and follow the protocols post-operatively to make sure you get a good outcome?
Great. Thank you, Dr. Jarman. As we begin to wrap up now, if your question did not get answered or you think of something later that you wish you had asked, feel free to reach out to us. Our email address is patientinfo@trace.net. You can also learn more or find a locally trained doctor by visiting our patient website, www.lapiplasty.com. If you go to our website, there is a Find a Doctor tool that you can type in your location by zip code, and it will bring you to a list of locally trained doctors in that specific area. Don't forget, as a follow-up, we will email all registrants an archived webinar link for reference. We hope you found the information presented tonight helpful. Dr. Jarman and I appreciate you joining us. Dr. Jarman, any last thoughts you have to share with the audience?
No, it's been a wonderful opportunity to be here on this webinar with you, Kendall. But I think it's the takeaway here is that I'm passionate. Passionate about this procedure, passionate about helping patients, and I firsthand for the past decade as I've been using Lapiplasty have seen just life-changing results with it.
Awesome. Thank you so much, everyone. Have a lovely evening.
Thank you.